Well, I'd like to thank you and Pat for the opportunity to talk, and I'm just glad this is recorded because Jens, it really hits the nail on the head, and it's a very sobering thought. He brings to light some very important questions, and I think things that we really need to discuss as we move this field forward. So Jens, as always, thank you very much for a beautiful introduction and segue. So these are my disclosures, which are relevant with respect to robotics. So I think Jens did a great job of talking about the Luddites. I'm not going to belabor the point. Jens said he's not a technophobe, but it's interesting as I speak now on robotics and we talk about the future of spinal surgery, we realize that there are a lot of spine surgeons who are questioning of technology and who have learned things one way, and I think that's fine. I think there's room for all types of interactions. I think the change is going to come with our trainees and how we train the surgeons of the future, and we'll talk about that in a minute. When we look at, we not to belabor the point, but when we look at any industry over the past 50 years, just like these telephone operators who thought that they had a very secure job at AT&T and that nothing was going to happen to them, their job security was there, we realized that with automation, in every single industry, jobs are changing. They're becoming more technical, and these type of entry-level positions aren't there. But we're really revolutionizing the technology aspects so that we need people to do other things. When we look at fundamentally, and Jens alluded to this as well, when we look fundamentally at the real change, I think the biggest change in neurosurgery and in spinal surgery in the past 50 years really will have been the advent of image guidance. So the ability to understand where we are in neurosurgery fundamentally changed everything. Randall Porter and I, when we were residents in Phoenix, had this arm here, one of the first positioning arms, and it was nothing short of transformational to be able to touch a patient's skull and see where the brain tumor was, when just a couple of years before, we would be touching the skull with your finger trying to figure out where the brain tumor was, and we weren't that good at it. There really isn't in the developing world now any brain operation that is done without image guidance. We really have been a lot slower to adopt this technology in the spine for sure, but it is standard of care in neurosurgery. You're not going to open up somebody's head without knowing where you are and being able to navigate. At this point, we're really at a nexus, and we really have had significant advances in imaging now with cone beam CT and our ability to image, directly in the operating room. Surgical advances with instrumentation and very slick techniques, lateral interbodies and different ways to do things. And then the advent of robotics. Now, imaging and surgery have come together already, and we have image-guided surgery. Surgery and robotics, the first foray with soft tissue manipulation in a master-slave environment was the Da Vinci robot. We now have robots in orthopedics, so in hips and knees. But what we were lacking was the confluence here between these techniques of imaging, surgery, and robotics, and bringing everything together. And that's really the nexus where we are at this point today. So I think Jens did a beautiful job of talking about not cons, but pointing out, I think, very appropriate considerations when we talk about adopting technology. I want to talk about three things: safety, both for the patient and the surgeon, efficiency, and then end up with how this is going to affect our trainees. So when we talk about the goals for robotic surgery, there are a lot of competing interests, and they are somewhat competing. We obviously want to capture patients who want less invasive surgery. We'd like to reduce radiation exposure, as Pat Johnson alluded to. The fact is we might be reducing things for the surgeons, but not necessarily for the patient. I would argue that for a single event for the surgeon, a higher dose of radiation may be acceptable if the outcomes are better for that patient, and that will remain to be seen. And then procedural consistency. How do we automate this? How can we plan this? And we look at just sort of where we are in the world and how we're doing. Now, in the last few years, there have been several meta-analyses really looking at the progression of accuracy as we've gone from freehand, conventional accuracy, to fluoroscopic guidance. up into 3D navigation. And I would argue that now with the advent of robotics, that 95% confidence level for screw placement is getting up into the 98 and 99% range. And what it's given us is an opportunity to rethink the way we look at accuracy. So what you see in the upper left here is how we plan the pedicle screws, and then we see here on the right how they were placed. So we're now able to overlay that plan in place and give us really a three-dimensional report card, as it were, of how we did. How did the screws go in? You know, it used to be not just in the 5-10 years ago when we would look at a CT scan, if the screws were all in bone, we'd be giving each other a high five. When we look at the measurement of this, though, we're really relegated to Gertzbein-Robbins, really an antiquated way of understanding our pedicle breach. These pictures are beautiful, but the reality is that with scatter artifact, being able to tell between a 2 and a 4 millimeter breach can be impossible in some CT paradigms. So the fact of the matter is, this is sort of where we are. This is really our report card as it is. I will tell you that, now we have an opportunity again, looking at in postoperative imaging, and I don't do postoperative CT anymore, but for the first couple hundred of cases with the robot we did, and you see here, things aren't perfect. And we realized early on that we were having a problem with some tip deflection, and we were able to change that by going into a burr. But when we look at these inaccuracies, we're able to learn. And I would argue that continuing to push the envelope and learn by what we're doing is going to affect the change really to make this technology safer. We're now to the point where we're doing three-dimensional volumetric analysis. We just published this a couple of months ago, but now we're really able to say, okay, what is the volume? How accurate are we? 99%, 95%? Are there breaches, etc.? So this has really opened up an entirely new era when we talk about assessing accuracy of what we do. And these measurements now can be made with machine learning in a very rapid fashion. And we're getting to the point where the post-intraoperative x-rays can be overlaid onto the preoperative CT to give us a volumetric report card, as it were, with how we're doing with screw placement. I would argue that, taking a patient back for surgery certainly has a risk, but the fact of the matter is, if in surgery with x-rays and go backwards and understand exactly how accurate you are, this is going to be a boon to the way we do things. So this is just highlighting a case. This was a poor gentleman who sustained this fracture. He was a taxi driver, actually, who got out of his car, and the car went into reverse, has this unstable fracture. And the anesthesiologist calls me and says, he also has a pelvic fracture and other injuries, and his hemoglobin 7.4. How much blood are you going to lose? And the reality is, the BMI of 50, doing this in an open fashion, may have been the death knell for this gentleman. He had pulmonary contusions. Preoperative hemoglobin was 7.6, and the postoperative hemoglobin was 7.4. You can see the blood canister here. So being able to do things in rapid fashion and being able to do things with a high degree of accuracy, I think, is going to change the way we do things. But this is a very, I think, powerful illustrative case of this type of technology. So the question of radiation, I think Pat talked about the potentially higher dose if we get a preoperative CT in a patient, but if we, we're always getting postoperative CTs for a period of time. But, the concern obviously has been for the surgeon as well. Randall showed a beautiful case of the prone lateral, but there is this, not an insignificant amount of ionizing radiation that we assume every day in what we do when we have the fluoro machine in the operating room. And not to belabor the point, but there have been multiple studies show that, as neurosurgeons and orthopedic surgeons who do spinal, we have a significant increased risk of cancer because of this radiation exposure. And interestingly, the thyroid shield and the gear we have gives you about a 2/3 reduction in radiation. It's not completely protective. So I'm done at this point. This is earlier this year. I'm throwing my lead away. I'm not taking any more x-rays. Hopefully that will bear out well. We talked a little bit about it, and Jens alluded to this fact of cognitive load reduction. The fact of the matter is that there's no doubt that when things are registered well and we're able to do, potentially not stressful, but the more mundane, sometimes part of the case, getting tactile feedback and 3D representation definitely decreases our cognitive load and can make the day more enjoyable. We're really looking for this efficiency. We're really looking for the ability to, swing throw the dart and have it hit the bullseye every time. That's really what we want. And being able to do that in a reproducible fashion. As this technology evolves, we realize that we really can't go backwards. This is 1964, NASCAR, they're taking their time. They've got the car out there, they're gonna do a little body work, and as he pulls over, fender's broken, we can go ahead and fix that. We use some high-tech shoes to do that. And this took a period of time. We'll get back on the track. When we look at spine surgery, and certainly in the open era, and this is still being done every single day in this country, big incisions, opening patients up, looking at our anatomy, and the master surgeon cannulating the pedicle freehand done, but we're not perfect. We fast forward 20 years, and that same iteration now takes under 13 seconds. The ability to change 4 tires, change the oil, change the gas is done in about 12 seconds. So there's a significant advance that's happened. It's happened now in surgery, where we can put in now 4 screws on average in 8 minutes or less as soon as we start the case. And that really changes things a lot. So the ability to plan, Ron gave a beautiful representation of. We won't belabor the point there. I think that we early on were able to look at the last cases of freehand versus robotic, and we looked at 28 consecutive robot cases and matched controls of 28 freehand. We definitely, as we started shrinking and collapsing the incision base and everything else, we did have less blood loss. But interestingly enough, as the length of the procedure decreased, the length of stay decreased, and patients were now going home reliably in a day after surgery, which is huge. And I'll show you about the learning curve, which was alluded to as well. There's definitely a learning curve. I think Jens pointed that out. Randall, everybody talks about it. It's definitely there. We found out there's about 4.5 minutes a case over those first 28 cases, to the fact now for a single level TLIF, we're now under 2 hours. And that took a while, but it takes a team, it takes dedication, but the reality is it can be done. And getting into that point now where we can take a junior or mid-level resident through an MIS TLIF in less than 2 hours is for me, will add several years onto my life for sure. So the learning curve, we talk about this, and again, not to belabor the point, but I think it bespeaks the fact that the whole training paradigm is changing. And when you look at the general surgery literature, it's ripe with lots of information about the learning curve with haptic and master-slave robots like the Da Vinci. That's there. We don't have the option here of having our residents sew grape skin on. We want them to put pedicle screws in, but certainly the decompression and the rest of the case are things that require skill, and that's not going to change. The millennials are driving this technology. They're hungry for this type of technology, and the fact of the matter is they're very adept at picking this up. Probably a bigger concern is the fact that we do not have as much time with our trainees as we used to because of residency work hour restrictions, and neurosurgery and orthopedics. They're both very complicated fields. Spine doesn't occupy the overwhelming majority in both of our specialties. We're having less time. This article from the New York Times was great. One of my former mentors, Robert Spetzler, talked about the fact that today's surgeons aren't very skilled because they don't do things with their hands anymore. And I guess that doing this doesn't translate into being a good surgeon. But I think we have to rethink for the next generation of how surgery is done and how we teach residents in an environment where we don't have as much time. So right now we're doing things with robotics in a very basic fashion. And Jens, you're right, we're putting just screws in at this point. But what are the other applications? Can we get to the point where we're doing more complicated cases? We're doing now pelvic fixation on a daily basis. When do we move into tumor resections and decompression, osteotomies, et cetera? We'll tell you that is on the table, and that will be coming soon. I think the reality is that this is a forward progression as we continue to move everything in this field together, and interaction between different therapies, different parts of the body, whether it's the brain, the spine, et cetera, coming in and out of these technologies, really we're going to sort of, give us a menu of options for our patients. So ultimately, I think, we've really been technologically driven in spine surgery. We really, certainly when it comes to implants, we really have just done an amazing job. In robotics ushers in a new era. And I think there's a learning curve with all technology. Figuring out how it works for you in your operating room, really that's the key. millennials are going to help us push this field forward because they're very interested in this technology. And ultimately, I don't think we're going to be going backwards. So with that, I'd like to thank Daniil and Pat and Jens for the ability to virtually join you in Seattle. And I don't know whether we're doing questions or what, but thank you very much, everybody.
Thanks again, Nick. Great to see you.
Great to see you too.
You have a retort, Dr. Chapman, or?
Again, the lamest thing to say, I will say, and that is I agree with my counterpart. The con man agrees that the future is here, and so denying it would make me a Luddite, which I declared not wanting to be. The question is reasonable applications, and the question is, how do we as surgeons who are ethically motivated trying to help our patients govern the field so we truly serve our patients best? So that's for me the biggest thing. And having metrics and studying what we're doing and learning from it and continuously improving it is a really big deal, and avoiding hucksterism and salesmanship. So as we're looking at augmented reality, we have some great displays that Daniel and Patrick are going to show us later. That's a great example for me. I mean, I'd love to have a single multifunctional goggle on, similar to our combat pilots, fighter pilots nowadays, and see the patient radiographically and do everything through a very small incision. That's the thing. And I'd like to measure the metrics of patient outcomes and publicize that honestly, but I don't see that happening. I see a development just really taking place where literally Joe Schmo down the street, that's not regionally intended here, can just basically declare themselves to a robotic laser, whatever surgeon, and the patients will run towards that. So that's, I guess, my fear is how do we roll out this technology in a fashion where we remain in control of it so we can honestly decide what is best for our patients.
So I think that's a great point, Jens. And I think, the reality is, and, now you're going to have, there will be multiple, there are multiple different robotic platforms and different ways of teaching. I think the most interesting observation, you hit the nail on the head, we all learn the same way. 25 years ago, the patients opened, we all learned the same landmarks, we all learned the same techniques. And now there's going to be this divergence, and there will be different schools of thought as things evolve. And that will also have to do with training. So you bring up a good point. And I think that at the end of the day, we need to be honest about not just complications, but where things go wrong and what the limitations are with the technology. Because, as the famous quote reigns, a fool with a tool is still a fool. And the fact is that, this technology, while enabling and potentially powerful for our patients, has limitations, and I think we need to look at that. But the reality is the world is going to become much more complicated now, because there's going to be different people doing different things. Almost, I don't want to say in silos. We always need to discuss this, but there will be different schools of thought.
Nick, there's a question. Can you discuss lateral screw deviations with the robot?
Sure. So it was very interesting when we started first publishing the accuracy. We noticed that there was a lateral deviation, or medial in that fact, mostly lateral. Couple things, depends on where you plan your entry point in the bone, but most importantly, the sharp drill had an opportunity on a precipice of bone as you started it at high speeds to become deflected. That has really all been eliminated now with the usage of a burr. So we'll come down on the bone, touch the bone, confirm accuracy, come back a couple of millimeters with the burr, go high speed, make a small divot into the bone, the drill goes in nicely. So it'd be nice to have one drill that does that, but the reality is that the burr has all been eliminated skiving. You can still get it if you try hard, but the fact of the matter is there's a technique, and that's just something, again, that's evolving with the technology.
Great. Thank you so much. We're going to move on. Do you have any questions? Thanks,
I got to have one. I got to have one for both you guys, and thank you very much for providing just incredible insight, knowledge, and expertise, both of you. Nick, you're a real innovator, and you're incredibly experienced. Jens' perspective is absolutely incredible, and the reality is we have to learn how to guide this technology. And that's why I've become involved in it. I've been involved in image guidance a long time, but I think we need to be involved in the direction of it because it's extremely limited right now, as Jens had pointed out. We put screws in the spine. That's all we do. And that's a big, huge quantum leap. But if it's going to be able to do anything useful other than put a screw in, it's a severely limited tool at this point. And I'm not seeing that it's going to advance a lot in the coming, whatever, years or even maybe decades. Is it going to be able to replace you with a curette elevating the dura off a bone in a revision case? I don't see it doing that. I see this as having a limited application at this point. And I'm not a naysayer, believe me, I've jumped on board with all of this stuff. But I think it has to have a healthy dose of realism as to what it can do. And I think that's incumbent upon us. I mean, we do have a young generation who wants to do this, and they're going to do some great things, and I'm all supportive of that. But I think that we just need to impart our knowledge. You guys are doing a great job. Thank you.
Thanks, Pat. Just one comment. I agree with you 100%. There'll be limitations, right? So the next foray might be bone removal, osteotomies, for instance, laminectomies with robotic assistance. A revision case where there's a big scarred synovial cyst, and we're going to add in some sort of soft tissue potential, that becomes a whole different foray. And it's interesting if we look at, vascular neurosurgery as a sister specialty. As a resident, you and I clipped hundreds of aneurysms. That's what we did. And as endovascular became better, what's left now? It's left are these super complicated, either revision or coils have come out of the aneurysm. And the cases that are done are much more complex because other technology has changed that. So it's never going to supplant, I don't think, the need for the master surgeon, but we may change the paradigm so that maybe we get things better the first time and it'll alleviate the big revision. So I agree with you. It's a work in progress for sure. Thank you.